Good afternoon, everyone. Thanks for joining us. We're going to give it a couple of minutes to fill up the room here.
Brett, can you see my arrow if I'm moving that around?
Yep. Yeah,
Okay.
I can see that.
Great.
Afternoon again, everyone. Thanks for joining us. We're going to give it about another minute to fill up the room. Afternoon, everyone. We'll give it about 30 more seconds here. Okay, good afternoon, everyone. Thanks again for joining us once again for our weekly Wednesday webinar series. Today's webinar is on the challenges facing women with bleeding disorders. My name is Brett Spitalian. I'm the Vice President of Advancement here at the National Haemophilia Foundation. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will pose to our presenter after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, April 2nd. I would like to introduce our presenter today, Dr. Paula James, Professor, Hematologist, and Graduate Program Director of Translational Medicine at Queen's University. Thank you for taking the time to join us today, Dr. James, and I will now turn it over to you to get us started.
Great, thanks so much. So I just want to start by thanking Dr. Valentino and the National Haemophilia Foundation and Brett for setting up this opportunity for me to speak to you today about a topic that's very near and dear to my heart, challenges for women and bleeding disorders. So these are my disclosures. I currently have research funding from Bayer. So I'm going to start with a case. Probably will be very familiar to many of you. So this is an 18-year-old woman who has heavy periods. She has periods that occur monthly, and the bleeding lasts for 8 to 10 days. Her heaviest bleeding is on her second and third day, and she's had problems with flooding, accidents at school, and she's been iron deficient since menarche. When you go into the story a little bit more, she also has had a return to the dentist after her wisdom teeth were extracted because of bleeding when she was 14. She bruises easily, her gums bleed when she brushes or flosses, and there's no family history of a diagnosed bleeding disorder, but when you talk to her, her mother had issues with heavy periods as well, and in fact ended up with a hysterectomy at a very young age. And so with that patient in mind, I'm going to proceed on with the presentation, and then we're going to come back to this case again close to the end. So why do I think this matters so much? I just wanted to set the stage a little bit in terms of the burden of heavy menstrual bleeding. And if we think about this historically, in the past, women during their reproductive years would have on average about 160 menstrual cycles. So menarche happened later than it does now. Women had more children than they do now, and there were extended periods of breastfeeding with earlier menopause. If we look at the situation today, women can experience up to 450 menstrual cycles in their life. Periods start earlier, less periods of pregnancy, shorter periods of breastfeeding, and later menopause. So disorders of menstruation matter now more than ever in terms of the health of girls and women. Heavy menstrual bleeding is a common problem. This number varies depending on the study that you read, but up to 30% of women at some point during their reproductive years report problems with heavy menstrual bleeding. And of course, that's not all related to an underlying bleeding disorder, but a significant minority, up to 15%, do have an underlying inherited bleeding disorder that contributes to this symptom. If we look at how heavy menstrual bleeding is defined, this is defined as menstrual blood loss of greater than 80 mils during menses, during one cycle. It's kind of a useless definition. And so there have been a number of studies that have taken a look at, okay, well, what are things that we could evaluate in the clinic that correlate with that definition of heavy menstrual bleeding that are easier for us to get at? So things like changing sanitary protection more frequently than every hour, being iron deficient, having iron deficiency anemia, frequently soaking the sheets at night, or periods consistently lasting longer than 7 days. These are the kinds of details that we need to be thinking about when we're taking a menstrual history and might make us suspicious of an underlying bleeding disorder. If we then think about what's the impact of heavy menstrual bleeding, we know this causes 2/3 of hysterectomies in reproductive years. As mentioned, it leads to iron deficiency anemia. It's an important cause of school and work absenteeism and leads to poor quality of life. And that's been shown in a number of studies, that the quality of life of a woman with a bleeding disorder who is iron deficient and anemic approximates the quality of life of an HIV positive man with hemophilia. And so this is really significant in terms of making people feel terrible and really affecting their daily life. If we think about what are the bleeding disorders that affect women, I think arguably the most common is von Willebrand's disease. We also see platelet function disorders in women, and we see hemophilia. And I have the word carriers in brackets because I think it's important to recognize that women can have hemophilia. And I'm going to touch on that a little bit later in the presentation. We also see women who have difficulties with other coagulation factor deficiencies that are maybe a little bit more rare than the deficiency of factor 8 or factor 9 that we see in the hemophilias. This is a huge problem, under and delayed diagnosis for women with bleeding disorders. If we take a look at what's the estimation of the prevalence of bleeding disorders globally by the World Federation of Hemophilia, it's about 1 in 1,000. And I'm in Canada. If we take a look at the Canadian numbers, that means there's over 37,000 Canadians who have an inherited bleeding disorder. But if we look at our national registry, there are only about 8,000 registered. And it's possible that there are people who have been diagnosed and not registered. But I think it's fair to say that there are thousands of individuals who have a bleeding disorder that have not yet been diagnosed. And I would argue that the majority of those are women. If a boy or a man presents with a joint bleed or a muscle bleed, there's never a question that that's abnormal. But for women who present with heavy menstrual bleeding or postpartum hemorrhage, where there's a spectrum of bleeding that can be considered normal, it's easier to overlook. And so women, if they do get diagnosed, have been shown to wait up to 15 years from the onset of their bleeding symptoms to getting that diagnosis. And so for the next part of the talk, I'm going to structure it around these 3 issues. What are the barriers to care? What are the barriers for women with bleeding disorders? But more importantly, what can we do about these barriers? And so the first is that assessing bleeding symptoms is hard. And there has been a lack of understanding of normal versus abnormal bleeding, particularly, as I mentioned, when it comes to bleeding symptoms that are common in women. So particularly for gynecologic and obstetrical bleeding. The lab tests that we need to make these diagnoses are challenging. They require a high level of expertise to run and to interpret, and they're not widely available. We also have problems with disease classification and nomenclature, and have kind of muddied the waters when it comes to what is VWD, or how do we classify a carrier of hemophilia. And so as I mentioned, I'm going to go through each of these in a bit more detail. So assessing bleeding symptoms is tough and open to subjective interpretation, I think both by patients, but also by healthcare providers. And symptoms can get normalized within families. So we're talking about inherited bleeding disorders. And so the patient I talked about at the beginning, it wouldn't be a stretch to think that if she has an underlying bleeding disorder, it probably came from her mother, who had a hysterectomy at a young age. And so I think that that results in abnormal symptoms being overlooked. Unfortunately, women's symptoms are sometimes ignored by healthcare providers. And so even if somebody has sought medical attention for heavy periods, it is still far too common in this day and age that I have my patients tell me, well, I was told that periods that last for 10 days are normal, that's something to be expected. And we really need to challenge and change that understanding. So one of the ways that we've started to do that is through the use of bleeding assessment tools, or BATs. These are questionnaires that help us standardize a bleeding history and allow us to quantitate bleeding symptoms. And what I mean by that is that the output of a patient taking a BAT or being administered a BAT is a bleeding score. And so we take the bleeding history and we turn that into a score. Those scores have been shown to be very effective screening tools, particularly for von Willebrand's disease, and allow us to distinguish normal and abnormal bleeding. And we've studied thousands of normal and abnormal individuals over the years to figure out what's a normal bleeding score for a given sex and age, and what's an abnormal bleeding score, and when does it tip and become something that requires additional attention and investigation. So there are a number of bleeding assessment tools out there. Most of the ones that you might hear about have evolved from this common ancestor that was developed in the early 2000s in Italy. More recently, you may have heard about the self-BAT, or the self-administered bleeding assessment tool. This was something that was validated and published by my group here at Queen's University. And if you're interested in understanding the self-BAT and how it works, I would invite you to have a look at our Let's Talk Period website. Right on the homepage, there's a link to the self-BAT. And so it is currently available in English and French. We are working to try to come up with additional translations of the self-BAT. And if you click on the test, you're taken through a series of questions about bleeding. So have you ever had a nosebleed? And if you have, we ask for additional detail about, well, what happened with that nosebleed? Did you have to go to the emergency room? Did you have to have your nose packed or cauterized? And you answer that question, and then the tool takes you on to additional questions. And so after you've gone through a series of questions, you come up to this readout that your bleeding score is normal. And at the beginning, you have to put in your sex and your age so that the instrument can figure out what is the normal range, because it varies depending on male versus female and with age. And so you could get this readout, your bleeding score is normal. If you are concerned, you still may want to speak with your physician. And then if you click on the red box, you actually get a PDF printout that you can take with you if you're interested in having that information when you go speak to your doctor. Or you could get this at the end, your bleeding score is abnormal, and it will tell you what the normal range is, and that you should speak to your physician about this. So To move on to the next issue, which is lab testing. As I mentioned, the tests that we need to do to diagnose inherited bleeding disorders are very specialized and require a high level of expertise. They are not widely available in most labs. These tests are strongly affected by what we call pre-analytical variables. And what that means is basically how have you treated the patient and the sample before you take the sample and run the test. And so the one that is of critical importance for women in bleeding disorders is the issue of sample temperature and transport. These samples are supposed to be spun and separated into platelet-poor plasma within 2 to 4 hours. What I see in Ontario all the time is that somebody's had blood work done downtown in the city where I live. That's where the blood work was drawn. But it was transported downtown to Toronto. And you can't get from Kingston to downtown Toronto within that kind of time frame. And what happens if you aren't careful about time and temperature is that you get false positive results. You also have to transport the specimen at -40 or colder, which means dry ice. And it's a huge pain in my butt that it's even allowed, that labs can even do this kind of testing on samples that they know haven't been treated properly. And this is absolutely a problem in the United States as well. You also need expertise to interpret the assays. You've got to have people who understand bleeding disorders to take a look at these tests and figure out what it means in terms of a diagnosis for a patient. And I just want to point out this great study that was done in the US by Julie Jaffrey and her colleagues, where they looked at 263 patients from 17 centers in the United States. And what happened if they were tested for von Willebrand's disease in a lab that was on site where the blood was drawn versus off-site. And what you can see is it was more common to have red or abnormal results in off-site testing for all of the assays that we look at if we're diagnosing von Willebrand's disease, which include the VWF antigen, the von Willebrand factor activity, and the factor VIII level. And in fact, on repeat testing, less than 40% of individuals were confirmed as having VWD. And so their conclusion, which I strongly support, is that VWF assays should be collected and processed at the same site under the guidance of a hematologist. And so we've got problems on both ends of the spectrum here. We've got people who have bleeding disorders that go unrecognized, and then we have people who get wrongly diagnosed with a bleeding disorder. And we need to get this right on both sides. So then to say a few words about disease classification and nomenclature. Historically, it would be fair to say that there was a lack of consensus on how we even diagnose von Willebrand's disease. So what lab tests should we be using? What cutoffs should we be using for those tests? The other thing that we've seen cause significant problems are terms like hemophilia carrier minimizing bleeding symptoms. And so I hear this time and time again that my patients are told, well, hemophilia carriers don't bleed. Boys or men with hemophilia bleed. And we need to think about what are we saying with a term hemophilia carrier, and what unintended consequences has that had for women who have bleeding symptoms. So this was an effort that I've been involved in for the past 5 or 6 years to try to address those issues of VWD diagnosis. And so this was a collaborative project that involved a number of partners, including the American Society of Hematology, the International Society on Thrombosis and Hemostasis, the National Hemophilia Foundation, who's hosting the webinar today, and the World Federation of Hemophilia. And so in January of this year, we published our guidelines on the diagnosis of von Willebrand disease. And to decide what we were going to tackle in terms of which areas around VWD diagnosis are the most important and which are the areas that we want to focus on, we actually did a very large international survey to have those priorities identified. And we ended up having input from over 600 stakeholders, and this included patients, caregivers, nurses, physios, physicians, scientists. It was the entire range of people who care for patients with bleeding disorders or patients who have bleeding disorders themselves. And so this was a robust way, I think, of us sorting out what we needed to spend our time on. Additionally, the panel, the guideline panel that made the recommendations and met over a number of years, had very comprehensive literature reviews and systematic reviews done for us by a methodology team. That group included multiple patients. And so our patients were full voting members on the panel and really had a significant influence on the way we worded our recommendations. And so in that document, we have made 11 recommendations. There are 3 recommendations on the role of bleeding assessment tools in the assessment of patients being worked up for a potential underlying inherited bleeding disorder. We talk about which diagnostic assays should be used. We talk about the role of genetic testing. I'm sorry, you guys could probably hear the beeping. My office is outside of a loading dock, and so hopefully that truck will go away soon. We also talk about lab cutoffs. And so what is it that we think we need in terms of the levels to make this diagnosis? And I think largely because of the influence of the patients on the panels, but also very much in line with what the physicians and scientists felt, we were generous with the cutoffs, meaning that if we were going to make a mistake, we wanted to make the mistake on the side of diagnosing an individual with bleeding and not missing an individual so that that person would have access to care. We also very critically identified future research priorities. And since the paper was published, I have discussions every week about what projects are we going to do next and how are we going to additionally address the things that are very important for the VWD community. Where do we need to be putting our resources? So this is another project that I wanted to highlight for you around hemophilia nomenclature. And so Robert Sidonio, who's a colleague and a friend, led this effort. I'm sure many of you are familiar with Dr. Sidonio. And so he brought together stakeholders from the scientific subcommittees of the Factor 8 and 9 groups from ISTH, as well as the Women's Issue group. And we came up with a proposal for the words we should use when we're talking about these patients. And so across the bottom here, you can see that we recommend diagnosing hemophilia in women or girls with reduced factor levels. And these categories, so less than 1%, severe hemophilia, 1 to 5%, moderate hemophilia, 5 to 40%, mild hemophilia, those are consistent with what is done for boys and men. And so we wanted to line this up and to have women be given the same diagnosis, the same access to care as men. For carriers with normal factor levels, or a factor 8 or 9 level above 40%, we split this out into those who have abnormal bleeding and those that have normal bleeding, so with and without bleeding. And so the term symptomatic hemophilia carrier should be used for a woman or a girl with a normal factor 8 or 9 level, but who has abnormal bleeding. And one of the ways of determining that is using the bleeding score, a bleeding assessment tool that I talked about previously. And the self-BAT on our Let's Talk Period website has been validated for use in hemophilia carriers. A carrier without bleeding and a normal factor level should be referred to as an asymptomatic hemophilia carrier. And our intention is that it's possible for someone to move from this category to this category if there is the development of bleeding symptoms over time. And so the manuscript describing this work is just being emailed around to the co-authors right now. And so will hopefully be submitted shortly, but already has the endorsement of many stakeholders in our community. And so I think will be published as I've presented here. And so before I move into the last part of the talk, I have been alluding to what I think is sexism in the management of bleeding disorders, that women's symptoms are overlooked, that we have a lack of research and a lack of resources and a lack of focus on the issues facing women. But I want to call it out explicitly. And so this is a paper that I was privileged to write with my friend and colleague, Dr. Angela Wyand, from the University of Michigan, where we talk about all of the things that I've been talking about so far, and really what a problem this is in our community, with suggestions for how we should address this and to try to improve things going forward. One of the things we talk about in this paper is that in the world of hemophilia, there's been an absolute explosion of innovation, which is so fantastic for our hemophilia patients. Extended half-life products, non-factor-based therapies, gene therapy. The management of women and bleeding disorders has been lagging behind. And so we called attention to that, and other groups are additionally calling attention to this. And I think I certainly feel a shift in our ability to say things like this out loud and to deal with them within our community. And so I want to make sure that I leave lots of time for questions, but I did want to take a few additional minutes to talk to you about other aspects of our Let's Talk Period project. And so I mentioned this earlier in terms of where you might be able to access the SELF-BAT. I have a growing team that works with me on this project, and I thought I would share some of that with you. So this is the homepage for Let's Talk Period. Calls out the fact that 1 in 1,000 individuals has a bleeding disorder, but most don't know it. Could you be one of them? And then gives you access to a number of resources. So in terms of some analytics for the website, this has been a really happy surprise for me. We launched the website in 2016, and there have been over 270,000 page views from almost every country in the world. And so even though the site is predominantly in English, with the French version of the SELF-BAT, there is an appetite for this content. And we've seen a steady growth over time of people who are using the website. And the number of unique page views is lower than the number of total page views. People are coming back. And so people find out about the site and have a look, and then maybe come back on subsequent occasions to take the SELF-BAT or to have a look at some of the other content we have posted. We're constantly refreshing and updating and posting on the site. So in terms of the SELF-BAT, almost 25,000 people have taken the SELF-BAT from 148 countries. And this is astonishing to me. When we launched the site, I had to make a decision about data control and access. And I'm a researcher, so I wanted everything to be a research study, which would have meant people would have to consent to even coming onto the site. There is a consent that has to happen to access the SELF-BAT, but other than being able to see an IP address and knowing the age and sex of the individual, there's nothing else that I track. So I don't ask people for any identifying information beyond those pieces. So I don't ask for name, I don't ask for postal code, and we aren't interested other than in having an idea how well this is working in that level of identification, which was a difficult thing for me because I was putting this information out there without necessarily being able to know what happened. thankfully, people have reached out. And so we've heard from people all over the world who have taken the self-bat, printed out that PDF that I described at the end of the test, taken it to their physician and been accurately diagnosed and started on treatment. And I see this happening locally. So I am now regularly receiving referrals from people who've taken the self-bat, who've gone to see their family physician, and who get referred to my clinic. I have had discussion with colleagues about additional ways of expanding what we might be able to learn about people who are using the site. But I think the decision, which I had to be convinced to make, but the decision to do this, to put this information out there freely, was a good one. And I'm happy that people are being helped by this. We have a number of other social media platforms that align with the website. So we have a Facebook page that looks pretty similar. The Facebook page has a steadily growing following as well. So almost 5,300 followers. I've had to learn a lot about social media. I was a very late comer to social media, and I actually wasn't even on Facebook until we started this project. So forgive me if I'm still a learner when it comes to some of these terms, but the reach of our content is over 1.2 million people, which is amazing to me, but I think speaks to the appetite that there is out there for people having access to accurate and reliable information about periods and about bleeding disorders. This slide's just a bit of an example of the kinds of things that we post. Shoppers Drug Mart is a big pharmacy drugstore chain in Canada. And so we posted about Shoppers starting a project to offer free menstrual hygiene products. We try to have a global perspective for what we're posting. So things about what's happening in Britain, things about the use of the birth control pill and how that could be used to manage periods. And what we see is with some of these posts, they really get traction in terms of getting people's attention. And there are links in everything that we do back to the website and back to the self-bat. And so this particular post, the night after we put it up, 166 self-bats were taken. And so I want to highlight another section of the website, which is in this resources tab. And so we've spent a few years now developing additional free resource toolkits to try to provide accurate information that might be useful for a number of different stakeholders. So there are infographics and information that was developed with nurses specifically in mind. And so I have two nurses who work with me in my clinic and who are part of my Let's Talk Period team. And they surveyed and engaged with their colleagues to find out what is it that nurses want in terms of helping to identify patients with bleeding disorders and helping to manage patients with bleeding disorders. So there's a series of infographics and other resources there. We heard time and time again, and I see this in the clinic, that primary care providers really need more education about bleeding disorders. And so we partnered with some local primary care providers to identify what their needs are and what kinds of things would they find useful in the clinic. And so we have a 2-page infographic that is available that talks about who should you be suspicious of a bleeding disorder? What are the characteristics of normal versus abnormal periods? How do you investigate them? What lab tests should you do? We really highlight the importance of iron deficiency and making sure that patients are evaluated for anemia and iron deficiency and treated. And then we give an outline for if a patient comes to you with this printout of the self-bat, how do you work through that with the patient and how do you interpret the information you're being given? And then locally, how do you refer the patient? We also started a really fun high school project where a number of years ago, pre-COVID, my team would actually go in to teach grade 9 health classes in our community and talk about iron deficiency, talk about menstrual products, what's available, how do they work. We would talk about pads and tampons and period underwear, menstrual cups, and really give the girls a chance to have a look at those things and talk about them and teach them what would be normal in terms of periods. And the interest in this was great, actually, and it became clear that my team couldn't teach all of the grade 9 classes, no matter how much we wanted to. So we developed a video and other resources that you can find on this page that are designed to be used in health classes anywhere to teach about these issues. We've also got a few other video resources, and there's a bookmark if you're interested that you could download and print. And we continually work on this. So we are working right now on some resources specific to hemophilia carriers that will be going up sometime in the future. I want to highlight that Let's Talk Period isn't the only initiative like this, though. And so the National Haemophilia Foundation, our hosts today, have a website called Better You Know, which really is focused on the same things as Let's Talk Period, that it's better to know if you have a bleeding disorder and how should you evaluate your own symptoms to see if you are at risk. There's an Irish initiative that's very similar. A friend of mine, a colleague, Dr. Michelle Lavin in Dublin, worked with the Irish Haemophilia Society to come up with Know Your Flow. And these things are similar in their intention. And I'm really just so delighted to see more and more resources like this becoming available. So I want to go back to the case. And so our 18-year-old heard about Let's Talk Period in school and went on the website and took the self-bet. And her bleeding score was 7. And so for an 18-year-old woman, that's an abnormal or elevated bleeding score. So she has excessive bleeding. The family doc did some initial blood work. So checked the hemoglobin and it was low at 112. The red blood cells were small. That's what microcytic means, and that's a sign of iron deficiency. And then the test that is the best at identifying iron deficiency, the ferritin, was done. And a ferritin of 8 is quite low. And so this diagnosis is iron deficiency anemia. And so other tests of coagulation that are widely available, the prothrombin time and the activated partial thromboplastin time, or PT and APTT, were done. They were normal. And so iron supplementation was done. But given the fact that an explanation for this abnormal bleeding score had not been found, and consistent with the recommendations on our website, the patient was referred to hematology. And so when she came to see us, we ordered specific testing for VWD. And so the PT and the PTT are very often normal in women who have von Willebrand's disease. And so, in men too. And so we ordered specific testing for VWD and got levels that you can see on the screen. We also checked to make sure that there wasn't a platelet function disorder, and that testing was normal. And so this is type 1 VWD. And so we made that diagnosis. If you look at these levels, the bottom end of the normal range in our lab is about 0.5 or 50%. And so these are entirely consistent with a diagnosis of VWD. So we arranged a desmopressin trial for this patient. Desmopressin is a medication that can be injected either intravenously or subcutaneously. It historically has been available as an intranasal product. Unfortunately, that has become unavailable here, I think, for a couple of years, which is terrible. But we arranged for this patient to be given desmopressin to be sure that it was effective at increasing her VWF levels. And we started her on tranexamic acid. The other name for tranexamic acid is cyclocapron. And so this is a medication that prevents the breakdown of clots. And so for reasons we don't completely understand, this is very effective for mucous membrane bleeding. So heavy periods, nosebleeds, bleeding from the mouth. This is a great medication. And so she was started on that medication, and then we arranged follow-up for her in our Women and Bleeding Disorders clinic. And so the way my clinic operates is that if I get a referral and a new patient, I see them in my own clinic because I can get them in faster there, evaluate them. And if that individual requires gynecologic care, then I arrange follow-up in the Women and Bleeding Disorders clinic that I run once a month with my colleague, Dr. Sophie Gibson from gynecology. And so she was seen in the Women and Bleeding Disorders clinic. Her periods were significantly improved on the tranexamic acid. We're now lasting about 6 days. She had improved energy and concentration. What commonly happens in the Women and Bleeding Disorders clinic is that there would be a discussion about additional options for menstrual management. So is tranexamic acid alone the right treatment for that patient going forward? And for some patients it is. Some patients choose to go on the combined oral contraceptive pill or use other hormonal methods of menstrual management, many of which are also forms of contraception. There would be a discussion around the Mirena IUD or intrauterine device, which is a white plastic T that's inserted through the vagina, through the cervix, sits in the uterus. It's a form of contraception, but it also decreases menstrual blood loss. And then we also have a discussion with our patients about surgical options for heavy menstrual bleeding. And so an endometrial ablation, which is a procedure where a patient goes to sleep, this happens in the operating room, and the lining of the uterus is either burned or frozen, and it stops or diminishes periods for about 5 years. We also will have a discussion about hysterectomy, and we certainly want to avoid hysterectomy if somebody could be effectively treated with one of these other strategies. But if not, or if the patient's wishes really are to go for hysterectomy, we are very supportive of that. And then it's very important that my team is involved because that's major surgery. And so we make recommendations around the time of the surgery to prevent bleeding. And so just as I wrap up here, I hope I've conveyed how important I think accurate diagnosis is for women with bleeding disorders. I think there is value from a diagnostic perspective in bleeding assessment tools. I think we need to be testing our patients in labs that know what they're doing and that provide high quality testing. And we are making strides in terms of fixing our historic problems with nomenclature and diagnostic cutoffs. There are growing resources out there like Let's Talk Period. And the reason for all of this is that, like our 18-year-old, we have effective treatments that improve quality of life. And within a fairly short period of time, it's easy to make people feel better, and a very rewarding place to work from a clinical perspective and from a research perspective. So I just want to end with a few acknowledgements. The classic Zoom meeting pictures of the COVID-19 pandemic. So some folks who work in my research lab, and then members of my Let's Talk Period team, with a few individuals who didn't happen to be at the meetings the day we took the pictures. I really want to highlight Dr. Kelly Howes, who's a family doc, who really helped us with the primary care materials that we've put up on the website. And so with that, I'm going to stop. Yep, my timing is good. So we've got about 15 minutes for questions.
Yeah, thank you so much, Dr. James. That was very great presentation, well informed. I will add that when you talked about the sexism in diagnosis, we got one of our participants that said hallelujah in the chat. I think we've got a lot of support there.
Thank you.
We do have several questions that came in, so I will start here with what can women do to advocate for themselves at the doctor's office? Additionally, what is the language that women should use when they go to the doctors to get acknowledgement that they are having abnormal bleeding?
Yeah. It's the most important and the most difficult question. And I don't want to minimize the fact that this is still a problem. I mean, from my end, we've tried and we are trying so hard to change this. And so when I teach the medical students about bleeding disorders, I take a patient with me. We did it by Zoom a couple weeks ago, but I think healthcare providers need to hear directly from women and the impact of these disorders and the symptoms and how important they are. So on our end, we've got to change how we're teaching, which we are working on. From a patient perspective, this is really tough. And I think the sexism that I was talking about is still really a barrier. I would say engage with your patient organizations, engage with NHF, in Canada, the Canadian Haemophilia Society, and look for resources on what it is that your primary care physicians need to know. It should not be that you have to educate your physicians about your problems, but sometimes I think you need to. And so you need to be armed with your own knowledge about your body and what is normal and what is abnormal, and take some of these resources that are being developed from the NHF website for primary care physicians and ask respectfully for consideration of your symptoms, ask for referrals, advocate for yourself. Many of us who run clinics like mine will see patients without referrals. And I know the US healthcare system is complicated and that there are insurance issues that come into play that I don't necessarily completely understand coming from the Canadian system. But I think asking explicitly for what it is you need. So I need to see a hematologist. I'm worried I have an underlying bleeding disorder. I'm worried that if that doesn't get diagnosed and managed, the next time that I sprain my ankle or that I get a tooth pulled, I'm going to run into trouble with abnormal bleeding. And I think not being overly litigious, but I do think that risk environment in the United States is something that could be used in your favor in terms of there could be real harm if this diagnosis isn't made and if I'm not treated properly. And then if that doesn't work, sick me on them. I don't know. I mean, there are lots of people in the United States who are as committed and as passionate as I am about this. The people who were involved in the VWD Diagnosis Guideline, if you take a look at the authors on that paper, many of them run women and bleeding disorders clinics in the US and would be fierce advocates for access to diagnosis and care. People like Dr. Wyan, people like Dr. Veronica Flood, people like Dr. Robert Sidonio. So there are places I think you could go for help and direction in terms of some of the time what happens in my clinic is, somebody will call and say, I'm hitting a roadblock. And then I say, okay, just come to clinic. And then I start the discussion with the primary care provider about, here's the diagnosis, here's what I think needs to happen. The other thing that we tell our patients locally is if you're going to the emergency room, if you have a diagnosis and you're having a bleed, call us first. And then we call ahead and we can say, hey, emergency room in Brockville down the highway from me. My patient's coming in. Here's the situation. Here's what I think you need to do for assessment. And here is what I would recommend for treatment. And if you get ahead of it, physicians are, I think, more receptive to hearing what should happen. I hope that was helpful.
Yeah, that was great. Thank you so much, Dr. James. Another question that comes in, why would someone with antiphospholipid antibodies bleed excessively during menses, not thrombosis, but soaking several pads per hour?
Oh, that's a good question. Okay, so antiphospholipid antibody syndrome is not an inherited bleeding disorder. It's an acquired thrombotic disorder, just as that person acknowledged in the way they worded their question. There is a rare complication of the antiphospholipid antibody syndrome, which is an autoantibody against thrombin, against factor II. And those patients can have terrible problems with bleeding. You really need a hemostasis specialist to take a look at your lab work and to see if that's the underlying diagnosis, because that requires specialized management. One of the most complicated patients I ever managed actually was a woman with antiphospholipid antibody syndrome and an autoantibody against factor 2. And there are strategies you can use against that autoantibody. Prednisone works, IVIG sometimes works. You can sometimes give plasma infusions that can be effective. So there are strategies there. That requires a real specialist in hemostasis to work with you to figure out the diagnosis and management.
Great. Thank you so much. Next question comes in. In your research, excuse me, and input in the community, have you seen in Canada certain parts of the population, such as economic, geographical, or race/ethnicity, having access issues more than others?
Yes. A colleague of mine in Toronto, Dr. Michelle Schultzberg, has been working on trying to identify these barriers, socioeconomic barriers, barriers that are associated with race. Yes, we definitely have those issues in Canada and are trying to make ourselves aware of them as much as we can and to come up with partnerships and strategies to address them. In Canada, and I think in the United States too, one of the things that's happened as a result of the pandemic is the explosion of virtual care. And in Canada, we didn't used to do virtual care that much because we wouldn't get paid for it. There weren't billing codes within our fee schedules. The government, when everybody had to stay home, realized that those were necessary. And we are advocating as hard as we can to not lose them. And I don't think we will lose them when the pandemic is over. So things like virtual care, I think, are a way of at least trying to get better access for some of the issues that were raised there. The other thing that we need to think about is representation. And so we need people of color. We need racialized individuals to go to medical school, to become nurses, to become physiotherapists, so that people can recognize themselves in their healthcare providers. And so that those individuals can do a better job of reflecting what are the needs of those communities so that all of us do a better job.
Yeah, great. The next question isn't really a question, it's more of a situation or statement, but I'll read this to you, Dr. James, and you feel free to comment on it, please. I am a carrier and also have factor 8 deficiency in the mild range. I'm now a senior citizen, and because I was not diagnosed till late in life, I have advanced arthritis in many joints. I now have been diagnosed with osteoporosis and had to begin treatment with Prolia injections. I would like to know more carriers who are facing this and what treatments are used. I've had some negative issues from the Prolia, but when I asked about treatment for this, my hematologist had no experience with it.
So ask your hematologist who does have experience with it then. There's a really fascinating emerging body of research that is looking at bone health in men with hemophilia, but also in hemophilia carriers and carriers with low factor levels in the level of mild, moderate, or severe hemophilia. And again, my friend in Toronto, Dr. Michelle Schultzberg, is running a study looking at this. The study was a little bit sidelined by the pandemic, but we're back to recruiting for it again now. And so I hope sometime soon we're going to have a publication that should be helpful for patients like yourself. And the theory is that having a bleeding disorder can lead to bone and joint health problems through a number of mechanisms. One is joint bleeds. We know that blood in the joint erodes the cartilage and causes osteoarthritis. There's also connections that are fascinating between von Willebrand factor and factor 8 and other hormones that affect bone metabolism, particularly a molecule called osteopetegrin. And that there may be defects in some of the bone mineralization pathways that we're just starting to understand. And so your question about, is Prolia the right treatment? We are working to try to understand that better. But if you got told by your hematologist, I don't know anything about what you're talking about, if this is appropriate, ask who would be. Because there are many people in bleeding disorder clinics like mine who are watching this space and who are interested in understanding this better.
Great. Thank you so much, Dr. James. Another question comes in similar to one from the one previously, but I will certainly throw it out there for you. One of the difficulties for women in getting accurately diagnosed is also cultural and being able to talk about abnormal periods, even among family members. Do you have any advice for these patients? Also, there's fear about being diagnosed and then not being able to marry. What do you say to people that are worried about actually getting a diagnosis?
Yeah, thank you for raising those really important issues. Part of what we wanted to do with Let's Talk Period is to create a safe space for people to learn about these things. One thing that heartens me all the time is that, in our posts, there's always a chat, and my team monitors the chat, and we block and delete anything that's inappropriate. That actually happens very rarely. What happens more in that chat is women start helping each other and giving each other suggestions. And so social media, I think, is a place to get some of this support and to learn about strategies that may have worked for other women. With our high school project, we're also trying to normalize talking openly about these things. And I feel like this isn't lip service. There is a shift happening in terms of people's appetite for being open about these things. The cultural issues that you raised are really important. And certainly within some cultures and some families, the diagnosis of a bleeding disorder is seen as a barrier to marriage or family. These are treatable disorders. So those are the messages that we need to get out there, that this diagnosis these things are so treatable. And we have lots of experience looking after pregnancy, managing labor and delivery, making sure baby's safe, making sure mom is safe. So I think those messages really need to be pushed, that it's better to know that you have this, because then we can protect you and keep you safe and make your life better.
Yeah, that's great. I agree. Dr. Valentino, I see you raised your hand. Did you have a comment you wanted to make?
No, I apologize.
Okay, great. We'll get back to the questions here. Dr. James, we've got period poverty is a huge problem across the world, including in the US. What impact do you think the patient organizations can do to make a positive impact in this area?
Yeah, huge. And there's movement happening here too. So advocate for free access to menstrual products. It's such a no-brainer. If girls aren't going to school because they don't have pads, that's going to have a huge effect on their education and their opportunities in life. New Zealand is a country that I have so much respect for, not only because they handled the pandemic well, but they made menstrual products free. At a minimum, taxes need to be removed, but I also support free access. I mean, and it's this issue of that our systems have been designed largely by men, and there are so many men who are supportive once they understand these things. But the comparison that we always hear is, well, toilet paper is free. That's something that people need in public. And I think we have to continue to advocate. We have to have women involved in leadership so that they can say these are the priorities. These things are really important, and they're going to improve the health of our citizens. And so I think NHF and CHF and the World Federation of Haemophilia, I think, can have a huge role in keeping those issues at the forefront and advocating. Period poverty is a huge issue facing all women, but especially women with bleeding disorders who need more until we treat them properly.
Yeah, well said. Thank you. We're coming towards the top of the hour, but we have a couple more questions, if you don't mind, Dr. James, if you can help field these. Yep. Great. Thanks for your time. In Canada, are you doing education for healthcare providers about the impact on sexism for women and girls with bleeding disorders? I think you really hit on something here.
Yeah. Yes. Things like talks like this, I get as explicit as I got today. And so thank you for responding positively to that. That paper that Angela and I wrote has actually probably got more attention than anything else I've ever written in my career. And so people are reacting just like whoever the person is that said hallelujah. People are just grabbing it and saying, like, thank you for saying this out loud. And so I had a call this morning with a woman who's in charge of Haemophilia Ontario, and we were very aligned on the need to explicitly chip away at these inherent biases within our system to try to improve the health of women.
Great. Thank you. And we'll take the last question here now. It said, you talked about Demopressin and tranexamic acid for VWD type 1, but not factor replacement, either plasma or recombinant. Why is that?
Yeah, it was because I had a specific patient in mind with that case who didn't need it. We were able to adequately treat her without factor. However, I think that anyone who needs factor, male or female, should have access to it. And in the management, so for the VWD guideline, there's two papers. There's one on diagnosis, and there was another project on management that was led by Dr. Veronica Flood and Dr. Nathan Cannell. And in it, they talk about the importance of prophylaxis, and it is not specific to VWD type. It's for those who need it for bleeding. So thank you for calling that out and giving me a chance to correct an unintentional misperception about what I said. I think people who need access to concentrate should have it.
Go ahead. Did you have something additional to say?
Well, I was gonna just edit myself a tiny bit and say that we have a lot of options for the management of menses. And so many times there are things that are easier than an intravenous injection to manage periods effectively, which I absolutely have used factor to manage heavy menstrual bleeding in my clinic.
Great. Thank you. So we're up against the hour here, Dr. James. I'd really like to thank you so much for taking the time to join us here. And I really think you hit on an extremely important topic that's really rung with our audience here. So thank you so much for joining us.
Yeah, thank you, Brett. And thanks to everybody who signed in. I could talk about this stuff forever. So I really appreciate Dr. Valentino and NHF giving me a chance to talk about something I care about so much.
Great. No, it's been wonderful. And we appreciate your time and expertise. I'd also like to thank each and every one of you for joining us. Please note that this recorded webinar will be available on Friday, April 2nd at hemophilia.org under the events tab with all of our archived webinars. Also available in the events tab is our upcoming schedule for weekly Wednesday webinars. Thank you again for joining us. And Dr. James, thank you so much. Take care and everyone have a wonderful week.
Thanks, Brett. Take care, everybody. Stay safe.